Okay, liar, liar, pants on fire. We are recording. Okay, chapter 20, insufficiency testing. I'll be honest with you guys, I hate this job, I hate this job. That was a Freudian slip. No, just kidding. I hate insufficiency testing because it's pretty difficult and I don't have a lot of experience with it. And on the one hand, it's really very basic. Is the blood going in one direction and one direction only? And there's a number of ways to figure that out. The problem with insufficiency testing is that you are mapping in detail while you're insufficiency testing, while you're drawing on the leg with gel everywhere, and the patient should be standing and they're old and the leg is shaking and that's, you can't do anything with the leg is shaking. So it's, but I also know people who are good at this exam and they love doing it. Well, it's also a very long exam to do both legs. A full study, both legs, is even for a practiced person is an hour and a half. That's a long time to be with a patient. Hopefully they're patient along with you. They're a patient. All right, so we really have two issues with insufficiency, and what we're really worried about today is the first one, CVVI, chronic venous valvular insufficiency. That's the valves only are insufficient with this one. So, and usually we're talking about someone who's genetically predisposed to have non-functional or absent valves. Sometimes they're not even there. And I've got a list of valve numbers that I don't think the book supplied. I didn't see it. And then the other one is CVI, and that's just more of a catch-all that includes CVVI. So chronic venous insufficiency, well, that could be valves or, this should really be or how about this? And or DVT. So because long-term DVT is obviously another way of blood not releasing itself or not getting out of the legs. So we have a way of defining this, and that's the CEAP classification. That's clinical, etiologic, anatomic, and pathophysiologic. But so I wrote it all out over there. But let me go back to this side of the screen and look at my pretty picture here and kind of zoom in on that. So I've drawn some things in here, and let's just go ahead and talk about that. We've got the, well, let's see. I didn't draw the deep femoral veins, so you don't know exactly where that's coming off, but we'll go all the way up here and call that the common femoral vein here. And the femoral vein is down here, so well, let's draw right inside of it. Femoral vein, proximal mid-distal. Our machines still say common femoral vein because the person who set it up was a dinosaur apparently. Didn't know that we were no longer using, I'm sorry. The machines say SFV, superficial femoral vein, and that's the old stuff. In fact, your book has a section where it talks about old terminology and new terminology. And of course, we have the, here is the saphenofemoral junction. Really important spot to look at when we're scanning. And soon thereafter, so oftentimes right away, you'll see another vein going off more laterally, and that is the anterior accessory great saphenous vein. That one, it goes down to the knee. Maybe it kind of branches off down here. Maybe it even has a decent sized branch that reconnects to the great saphenous vein. Who knows? But generally you don't really follow it past the knee very often. There's another one that can be seen going more medially. And of course, this is the right, by the way. Do I have that on top? I did before. I think I erased it or something. This is the right leg. And the reason why it's significant is because, well, the saphenous vein, well, let's see. So this is what was this again? Posterior accessory great saphenous vein. That's going to go obviously posterior. So you're not going to, the patient's on their back, you're not going to be following that very far because it's going to go around the backside of their thigh. And then, of course, we have the great saphenous vein. Kind of jumping back and forth here between deep veins and superficial veins, but I think, oops, I lost my V. Great saphenous vein. Oh, somewhere there's a knee here. You know what? We're gonna say there's. You know what? I'm just gonna draw in a kneecap. There's a kneecap. A lot of times on the great saphenous vein, as if you're scanning it right above the kneecap, you'll actually write an AK. Of course, the word knee does not start with an N, so it's AK above knee, BK below knee. So that's going to be popliteal vein is behind the knee. Of course, this is dropped down, and these veins, we haven't followed it yet, and we probably never will because they never get DVTs. These are the anterior tibial vein. You can put VV if you want. I'm just going to apostrophe S, ATVs, anterior tibials. And I'm drawing everything obviously flat here. So, well, we know that these, I'm just going to draw this in quickly and then erase it. We have the paraveins and the posterior tibial veins as well. That's going to get, let's get those out of there. And then as we come down a little further, we have a small saphenous vein, right? Not short. What are the? Well, yeah. If it's a great saphenous vein, then they've settled on small saphenous vein. They used to call it short saphenous vein. Okay. So deep system, superficial system, and there's something I didn't draw in here. There's a couple of other things that go on, right? There are like an intersaphenous, veins, and more important in the study of a insufficiency study, you're doing insufficiency studies, would be, let's just do one here. I'm just going to do one, and that didn't work. Try that again. Here we go. Here we go. took a big bite out of my vein there. And these are the, of course, the is it perforator, whatever. You guys already know I can't spell. I'm not hiding anything. All right. The perforators, and these guys have valves. Let's draw like a tiny little valve in here. And that's important to know. Actually, what's really important to know is how the blood is traveling through the leg. So let's start low. Is this low enough? All right. Here we have our, this is the calf pump. Now the calf pump really relates to the deep veins. So these deep veins, they purposely hold a lot of blood. In fact, there are sinuses attached to these veins that actually hold large amounts of blood. I used to be able to find a really awesome sinus in one of my calves. I couldn't find it the other day, but it was really cool. And you'd squeeze my calf, and a lot of blood would head up, and then that sinus doesn't fill right away, guys. Remember, when you use the calf pump by squeezing it hard, squeezing the calf, it takes 20 seconds to really fill it up again. So if you need a lot of flow, you need to fill that up again. So the calf pump there, and that gets blood going uphill. Let's see, I need a view. Let's use purple because it's pretty and it's not red. So as you squeeze the calf, yes, a lot of blood travels up the deep system. But also you're going to end up squeezing the saphenous vein and the small saphenous vein. So blood travels up the saphenous system. From there, it preferentially will go down into the deep system. So for the most part, our blood travels from superficial to deep. So there are 3 possible locations, and this depends a lot on genetics. It depends on formerly having a DVT, on where one can get reflux. So some people could have reflux only in the saphenous vein. Some people could have it only in the small saphenous vein. Some people, just genetically speaking, they have bad perforators, and so they have perforator reflux.
So I have a question. Okay, sorry. So whether the GSV or the SSV, are both of those still considered normal, like reflex, or no?
So no, well, no, reflux at all is not normal. Is that what you mean?
Yeah, like going back to your other statement where you said some people have it in the SSV and some people will have it in the GSV. So either way, it's abnormal, right?
Oh yeah. It's all reflux is abnormal. It's just for some reason genetically, people may have more of a propensity for the great saphenous vein or the small saphenous vein, and some people have a propensity towards the perforators. The deep veins, some people have a propensity to not have good valves there as well. Although with the deep vein, it could be previous clot that has since been cleaned up, but that clot it ruined the valve. And so the blood's traveling through the deep system, but the valve has been maybe permanently left open, and the barn door is open and all the cows are running back and forth. So, so that's a possibility as well. So a lot of times people with deep vein thrombosis or a history of deep vein thrombosis will have reflux due to that. Other people are simply born with bad veins. So valves in general. Here, let me just show you this really quickly, because I have a basic system right here of a deep perf and a superficial. You can see the direction of valves. The way these work is they easily open in that direction, and then hopefully close when blood goes back to here. And so it cannot pass back down. And of course, if the valve is structured incorrectly, it will go backwards. Like such as this, you might have a valve that only closes this far, then you'll have a constant leakage of blood here. It's kind of cool in color when you find one of these valves. You squeeze the calf, and what you end up seeing is a constant, let's just give it a little bit of red, just like a little constant, oh, I keep doing that. Be careful. Constant backwards flow. And so you'll see like, a little red flow right here, assuming you have your vein blue going upward blue, and you'll see red, and this will last maybe a second, 2 seconds, 3 seconds before it finally ends out filling the vein till it maybe gets to this valve, and so the whole vein needs to fill, in which case it won't last very long. If you have multiple valves that are bad, that reflux can last amazingly long. It's like you squeeze the leg and you're waiting and waiting and waiting and waiting, and blood is just going backwards and backwards and backwards. Crazy. So normally, let's make that blue because it's blood. Normally it's down there. Of course, some's going to go this way, but go this way. All the way back to the IVC and the heart. We have different times. You know what? I might as well give you the times since I have this right. No, gosh, it's not towards till quite a few pages in your book, so I'll hold off on times. All right, so what do I have? Oh, I have numbers. So these numbers, they're not in your book. So therefore, honestly, they won't be tested on them, but it's still good to know. So your IVC number of valves, that's not hashtag, but that's a V. Number of valves, usually 0 in the IVC. We don't have valves in our IVC. Gosh, I had a hard time finding this information. This should be really external iliac vein, external iliac. Some people have 0, some people may have 1. It's not a set thing. Common femoral vein, most people have 1. These are valve. Femoral vein, of course, that's a long vein, so 3 to 4. Different books are going to tell you different things too, by the way, guys, but this is just estimates. Let's see, the pop can be, I have 1 to 3. Actually, I think I saw also 0, between 0 and 3 as well, but that's okay. These are just estimates, only calf veins. So that's anterior tibs, posterior tibs, and perineals, all of them. Between 8 and 19, that's crazy. I can't imagine 19 in any single vein. That must be like both veins together, like both ATVs. It's impossible to have 19 valves in a row. Let's see, great saphenous vein, 10 to 12. Yeah, well, it goes from your groin all the way down to your ankles, so that's certainly possible. And then the small saphenous vein between 1 and 8, so that's pretty variable there. Let's see. Oh, and I should probably say kind of a couple of more important valves that are consistent is the so-called terminal valve. Of the, so this is the terminal valve of great saphenous vein. And then there's usually a pre-terminal valve, which is a little farther down. And those are fairly consistent. So you should try to find those. In fact, we could try to find some tomorrow. Let's see. So chronic clinical terminal valve, pre-terminal valve, 1 page gone. Prevalence. Oh, so your book is not at all clear, is it? I don't know if you guys noticed that. I certainly did. The answer, and I do have answers apparently. How did you guys get a little small? Put you here. Yeah. Let's see all your beautiful faces. Okay. The book, I can't remember which page exactly it ended. Yeah, prevalence. Let's see, the last sentence on the page, I think. No, well, the last, CVVI valves is prevalent in many different populations, affecting both men and women. Prevalence of varicose veins varies between 2 and 56%, which is kind of one of those numbers has to be really wrong, right? I mean, 2 and 56% in men and 1 and 60% in women, which is basically statistically a dead heat. Men and women, dead heat. Prevalence the same. Varicose veins are associated with valvular reflux, blah, 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 blah. Very next page at the top, veins were noted more in men, 40% than in women, 32% varicose veins. And general population registered in clinics of Edinburgh. And then the answer given. Oh, it's, sorry guys, but this is really, this kind of stuff just gets me. 1B, women. So I'm not sure how they get women out of that. One study says that it's a dead heat. The other study says men have more. I can tell you one thing. You'll see a lot more women getting workups in vascular labs. Now, there's a couple of reasons for that. One, women are probably a little more concerned about vascular varicose veins than men are. So that's one thing. Men tend to be belligerent, and so we don't go in as often. Also, our varicose veins tend to be a little bit deeper under the skin, so they're not as noticeable and perhaps not as painful. It takes a little bit longer for them to become painful. And they will, by the way. If you have varicose veins, it's better to get it taken care of before you get to the point of heavy pain and heaviness feeling. Okay, so prevalence, look guys, I'm gonna say it's about equal, men and women. And I did some research on this. I did have a hard time finding a study that said definitively one way or the other. So I say equal, your book doesn't. However, they are more readily seen in females. So there's different stages, right, of varicose veins and everything that we see. myself a lot of room. That's okay. Let's just zoom in a little bit. Use this, draw that. And spider veins. Da-da-da-da-da-da. Spider veins or telange. Now that I'm gonna have to. I always thought it was telangiectasis, but I guess it's just telangiectasis. So remember, ectasis is a widening, unnatural enlargement of usually like a vein or an artery. So spider veins. Spider veins, you know, when I looked up spider veins, the first thing I saw were they were all over people's faces. So that's obviously not necessarily reflux in the face, unless they do a lot of handstands. Could be doing a lot of handstands. Reticular veins are basically just larger connecting veins, and what you can really see crazy directions, some of those. So this person actually has spider veins and reticular veins here, reticular veins there. So these are basically venules. Other things that, other visual things that we can see is edema. Now, edema is not only with varicose veins. When it is, it's because the vein is holding so much fluid that it's just leaking out, and it might be even getting down to the arterial arterioles, capillaries. It gets down to the capillary bed. It squeezes out in the capillary bed, but then it can't go back in. The way fluid gets back into the capillaries is by the lower pressure of the veins. Well, if you have very high hydrostatic pressure because of all that blood volume laying there, you can't get blood back into your veins, and so it leaks out in the capillaries and it stays out. So varicose veins, this is of course what we're talking about today, but yeah, medications, infections, yeah, cirrhosis, sure, kidney failure, congestive heart failure. This person has what's called pitting edema. It means you press on it, you squeeze it with your hand, you take your hand away, you see your fingerprints all over the place, and that's very common. Other things is discoloration. This is I'm not sure why. This is the gator region. That's where gators get you when you're walking in the swamp. Now that's the gator region of the leg. I don't know where the term comes from, but we have some discoloration. So once again, we have this blood is escaping the capillaries. Everything's under too high a pressure due to hydrostatic pressure, and those capillaries are open a little bit too much. And proteins. Blood, as well as in red blood cells even, are making their way outside of the vessel, and they're breaking down, and actually it will damage the skin. That's all those proteins, all that blood, all that stuff that's supposed to be in your blood vessels. Once it gets into the tissue like that, it causes problems. And if it causes really bad problems, it can ulcer. Venous ulcers and arterial ulcers are both a thing. Arterial tend to be from a total lack of blood supply. Venous ulcers are because stagnant blood supply. Let me just introduce a term really quickly back up here. And that is phleb, as in blood. Is there an O? I think so. Phlebo edema, or it's just phlebedema without the O. I wrote O down, but I don't think I was going by memory, which is never a good idea with me. Okay, I think, let's see, phlebedema. Discoloration, oh, hardening of the skin. Let's say like right here. We're gonna call that, and it will be hard. You'll feel it with a gloved hand, for God's sakes, I hope. Hardening of the skin, that is lipodermatosclerosis. Sclerosis. Sclerosis is hardening of the skin, and then ulceration and discoloration, yes. Well, these are some of the visual things that we can see. And honestly, guys, I never used, I've got to get back to those other pictures real quickly. I never used this, but then again, I was always a radiology ultrasound tech who happened to be pretty good with vascular. I was never in a specific, well, I was in specific vascular labs, but not very often. So I never used this, but they make a pretty big deal out of it, so I think we should at least talk about it. Bree, you scare me. All right, clinical. Just the background is just, I don't know. So, CEAP classification, oops. Clinical, etiologic, anatomic, pathophysiologic. So if we're going to be doing this and we run into the clinical, and give them a C0, that means 0, as in nothing. At this point, you're probably done. Let them go. No, maybe not. C1, telangiectasis or reticular veins. A lot of us have those, and doesn't necessarily mean we have underlying problems. Like I have them in my feet just a little bit. I'm not exactly worried about it. But if you have them considerably around your legs, then maybe. C2, varicose veins. See, we're at varicose veins and we're only at C2, which tells you that it gets a lot worse. C3, edema. C3PO, a unit helps that. If I had thought of that one earlier, I would have had something written down. Okay, C3, edema. C4, skin changes, and then there's major and minor, or minor and major. C5, healed ulcers, and C6, open ulcers. Once again, you will be using gloves, please, at all times. Etiologic. What causes this? Etiologic. EP. Is it just valves? CVVI. Chronic venous valvular venous insufficiency. ES, just over here. Chronic insufficiency. Venous insufficiency and or CVVI, secondary to DVT. So we know there's a DVT or there's past DVT and it caused the problem. So that's something you have to know in advance. CVI and or CVVI, congenital. Congenital, I can't think of a congenital problem other than valves, so I'm not sure, now that I think about it, what kind of just general chronic venous insufficiency would they have if it weren't valves? I can't think of another reason for it other than DVT, which is not congenital. I suppose. EN, unknown. In other words, you haven't seen the patient yet. You know, so if you haven't seen the patient yet, you have to put unknown. Anatomic, deep. Is this a deep venous problem? Is this a superficial? AS, AP, perforators. And of course, we could have combinations, ADS, ADP, ASP, ADSP, and AN is 0. So if we're talking about an AN, we're probably talking about a healthy individual that just came in for a study and they're fine. Pathophysiologic, what is it causing? PR is reflux. PO is obstruction, chronic obstruction. PRO is a combination, so obstruction causing reflux, and then of course PN. I guess N stands for nothing. Nada. That would be nothing. PN would be nothing. So on your homework, we'll talk about that. I know there's a question. Here's I skipped clinical severity score and then disability score. I didn't write in here, but so these are different ways of, you have the CEAP classification, clinical severity score, so how bad, but that seemed to be rather a little bit redundant. And then disability score, 0 is asymptomatic, 1 functions normal, however there's some pain. So I'm sorry, with the asymptomatic one, this is someone who you could visually see some problems, but they don't really feel it. So they are asymptomatic. Function, number 1 is a function normal, 2 function with compression, functional with compression, as in compression socks, which by the way, Nana likes to give out compression socks, so we'll bug her on that before you go out and stand all day long. It's a good idea to have compression socks, at least level 1, level 2 compression, so that they help keep blood out of the calf. And then disability score, non-functional. Person, doesn't matter if they wear socks or not, they are not walking around. Treatments. We talked a little bit about this already, really. Let's just throw this over here. So treatment. We have stripping, and no, that's not Jaguars or whatever it's called. Stripping is stripping the vein, the offending veins out of the body. Ligation, tying off offending veins, perhaps with perforators. You can ligate the perforators so they're no longer functional. Thermal ablation, that's the one that I'm most used to, because that's the one I'm most familiar with, because that's what we were doing a lot of, and that's putting this could be a laser, radio frequency. There's chemical ablation. Chemical sclerotherapy. So sclerotherapy. So remember, all of these, you couldn't do this to the artery. You can't just remove an artery and be like, okay, you should go home now. That's not how it works. But these veins, you can remove the offending veins, and the rest of the veins will usually handle the problem or handle the blood load. and phlebectomy. You know what? Phlebectomy. It's Stephanie, right? Stephanie, yeah. Stephanie, I gotta be honest with you.
What's that?
Well, the difference, I always just, I think I'm making an assumption. I'm a little embarrassed. Venous stripping, please don't. Venous stripping, please don't. No, I didn't ask for that. All right. I got slow internet today, so let that come up. Safari couldn't open the page. Okay. Well, do you know the difference between phlebectomy and stripping? I mean, I kind of thought they were the same.
Stripping is what they used to do back in the day. And before they would put the catheters, they would literally like go in and strip the vein out. You know, like,
Yeah.
So they would like cut sections and then take out sections. So
Yeah.
it's the same thing, but they're not taking out the GSV. It's like the bulging veins. So we close down the GSV with the treatment, and then the phlebectomy would be those bulging veins.
Okay.
Depending how big they are, do the ligation where there's no, and then just like take them out too.
Oh, okay. So I guess I knew what stripping was, but I didn't realize that phlebectomy would be all those other veins, those other large veins, and just ripping them out.
It's kind of the same thing, just different veins, I guess. I don't know.
Okay. All right. So these are all, by the way, guys, I should have said this before, these are all superficial veins. We're generally not stripping, ligating, thermoblading on the deep veins. So these are superficial veins that we're doing this. Did I give myself enough room? Well, how about this? I got a little bit of room for the deep veins. Well, it kind of is, it's a little bit different story here. If the deep vein has, the problem is DVT, then it's anticoagulation. Anticoagulants. Anticoagulants work, by the way, because there's also thrombolysis in here. Well, let's do this. And then thrombolysis. Well, I kind of like, it stopped me for a second. I'm like, wait a minute, what's the difference? And then I remembered, like, oh yeah. Thrombolysis is, that's powerful. That you generally put that right at the site of thrombus, and you lyse it out. You try to dissolve it. Anticoagulation is more, you give the patient a blood thinner, and the body does the work. So you're just helping the body get the work done with anticoagulation. You're thinning the blood, the body will do the rest. Thrombolysis is a little more aggressive. Let's see what else we have here. We could stent. So literally putting a stent in a vein. I've honestly never seen it. And this I've never seen either, which this is actually really cool. I didn't even honestly know this. Valve replacement. I mean, that is crazy. You wouldn't bother with a valve replacement up here in the superficial because we just take it out. We don't care. Just take the whole vein out. Some other vein will deal with it. But the deep veins, you cannot remove those. You got to clean them up. Apparently you could do a valve replacement. And I've got a picture right over here of a little valve. On the tip of a finger. So not sure, I guess they sew that into the wall, or the little fish hooks, they stick it in the wall, but in any case, blood goes up and it can't go back down. I thought that was pretty cool. So deep veins, anticoagulation, thrombolysis, valve replacement, and stenting are really the only things we could do. Superficial and, I should say superficial and or perforators. They can be stripped, ligated, thermally ablated, chemical sclerotherapy, and phlebectomy. So the exam, oh, I hate the exam. I hate the exam. We'll talk about those pictures later. Okay. Standing. Well, actually, before they're standing, we're going to do a quick DVT study. If you find acute DVT, which would be pretty unusual, but possible, you're done, because the only thing they were going to worry about at that point is the acute DVT, because they're not so cute, they can kill you. They cause a pulmonary embolism. If it is obviously older DVT, then DVT that has begun to dissolve and even reopen, then you can continue with the exam. Okay, so the patient is standing. Great saphenous vein. If you're, what do I have? Great saphenous cuff. Okay, I got this from the book. All right. So there's different ways. I don't think your book really gets into this. So let me just tell you. Some locations will just have you look at the great saphenous, small saphenous veins and the perforators. But a lot of times that's actually not the problem. It's the deep veins that are the problems. And so you really should be looking at the deep veins as well. So let's just start with the deep vein thrombosis issue. With the patient standing, you can, and if you have an automatic cuff, which I was never given, which sure as heck would have been nicer, an automatic cuff is one that squeezes quickly, holds for a second, and then releases. So obviously you want blood moving up quickly, and then you need to release to see what happens next. And the waveform is going to be similar for all of them, although there's going to be different times involved. So let's look at this waveform that I have on the screen. I have on this waveform antegrade, in other words, back to the heart at the bottom. So this is positive flow or antegrade flow right here, and this is negative flow, backwards flow over here. You don't have to have it that way. In fact, let me do something really quick. That is not what I wanted to do really quick. There is nothing stopping you from doing an exam. Upside down. So, can I turn you? Oh God, what just happened? I better stop right there. So I just flipped this. There's nothing saying that you can't have antegrade up on top and retrograde on the bottom. In fact, when it comes to this particular exam, a lot of people do seem to do it this way. I still prefer, please tell me you're going to go correct. There we go. I still prefer to have it like this. Towards the heart, blood, veins are supposed to be below the baseline. This is the way I like it. So anyways, well, right here, what's this? Of course, this is an augmentation, right? augmentation, and then reversal. Now, always, no matter what vein you're looking at, if you see this, that is bad. That is reversal of flow, and it's too much. If we were to see instead, closer here, if we saw this much, that's fine. We don't care about little milliseconds of reversal. That's totally expected. It's the longer time frames that we're worried about. Now, let's say every one of these is 100. Let's start right here. So 0, 100. This is milliseconds. Oops, not meters per second, millisecond. 200, 300, 400, 500, 600, 700, 800, darn it. 900, 1,000, and you get the idea. Now I will tell you what is bad. I need to kind of get back into talking a little bit more about the exam, although actually I think in lab is a better place to physically talk about the exam, because I'll tell you a little bit, and then we'll talk about it in lab too, because I think that's just a better location. Let's see. No matter what you're looking at, this is bad, because I've gone out past, by the way, 1,000 milliseconds is also 1 second. Okay, 1 second. So on the saphenous veins, great saphenous vein, small saphenous vein, if you bypass 500, saphenous, I'll call it the saphenous cutoff time. Anything less than 500, if it's less than 500, in other words, if we did this, for the saphenous vein, it would be okay. Let's see, the next one. And I'm getting this out of a box, guys. I thought the book didn't have it, and I finally found it in box on page 286. Okay. This is the cutoff for deep veins. Deep vein cutoff time. Just remember this. I'm going to keep saying it. This is time. So in other words, if it did that in the deep vein, it would be okay. It wouldn't be good in the saphenous, but it'd be okay in the deep vein. And then, let's see, 350 for the perforators. So here's our cutoff time for the perfs. So the perfs cutoff time is 350. So that kind of makes sense. The perfs are small. They're just going from one vein to another vein. They got one little valve in there. You shouldn't be giving them a lot of time. They should close and they should be done doing normal amount of backfilling in 350 milliseconds, or in other words, 0.35 seconds. Saphenous veins, Well, they're bigger. They are definitely bigger, but they have a lot of valves. And so even though the great saphenous vein is quite a long vein, it should have considerable amount of valves. So half a second really is what we accept in the saphenous. And then the deep veins, that's deep. And so we allow up to 1 second. Oh, I didn't. Okay, my notes just ended, but I realized we haven't spoken about this. There's this in here that we're talking about plethysmography, photoplethysmography, aeroplethysmography. We talk about that. I've got the page. All right, I don't know where it is. We talk about it soon enough. We talk about with arterial exams, the lower extremity arteries. We do plethysmography. It's the same, sometimes the same exact equipment, but a little bit different in how it's used. Now, let's explain this. Let's see, 4 and 5. Yeah, we got plenty of time. You guys, by the way, if you guys need breaks, just let me know. I'm kind of just this semester just going right through. So this first guy here this is plethysmography. Now when it comes to do I say this? Yeah, I'll go ahead and say this. Obviously this is just a cuff, right? You guys are familiar with that. It's the same type of cuff that's used on the arm. In fact, it might have been used on someone's arm just 5 minutes before this. What they could do though is they could find blood pressure just the normal way. What's your leg blood pressure rather than your brachial blood pressure, which is your arm? They could find the ankle blood pressure. Okay, fine. But they could also, and in order to do a blood pressure, of course, we're filling it so much that we squeeze the tissue so much that we actually close off the artery. You guys know how hard it is to close an artery. So that's what we're doing when we're doing a blood pressure. But what if we squeeze the cuff to, let's say, actually the air plethysmography, only 10 millimeters mercury. That's nothing. That's a snug little feel. 10 millimeters of mercury, and we have a very sensitive equipment to look at that. And what happens is there is back, so obviously where's the cuff? Okay, well this person's toe cuff. All right, we'll talk about the toe cuff then. Doesn't matter, it's the same difference. Pressure comes in from the machine into this toe cuff, expands the cuff. Now it could hold that expansion indefinitely, just holds it there as long as there's no leaks. With arterial, we could actually see a pressure wave going back. And with an arterial plethysmography, we actually get, a waveform. Similar to our Doppler waveforms, but of course this isn't Doppler, this is literally pressure, but it's the pressure from the same thing that causes Doppler, which is our pulse, right? With venous plethysmography, what they can do is get a baseline of how much pressure is in that toe, squeeze the calf, perhaps use another cuff to squeeze that calf, get all the blood that you can out of the calf, and then wait for it to leak back in. how long does it take to leak back in? Does it take 10 seconds to come back to normal? Does it take 20 seconds to come back to normal? And so what happens is, if it refills too quickly, if refill time is too fast, then that supports, doesn't, these are not as accurate. They're quicker than what we have, and nurses can do them, doctors can do them. I don't like to do these. Why would I? I'm an ultrasound tech. I'm not a nurse. But if the refill time is too fast, then it supports the idea that there is reflux. Now let's think about why that is. Normally, only arteries fill, I'll just say they fill the veins through the capillary beds, they fill the toe, they fill the leg. Arteries fill with blood, and they fill everything else with blood in turn. But with reflux, veins fill too. Right? That kind of makes sense. So if we only have the arteries filling, well, it goes down through the arteries, the posterior tibial arteries, the anterior tibial arteries, the perineal arteries, and they branch out and they go through capillary beds, and they come out of the capillary beds and the venules and the veins, and then that takes time. On a normal person, that takes more than 20 seconds of time. But if it's taking 10 seconds to refill, then not only is the artery filling the vessels, but there's backwards flow. There's reflux flow also filling the veins. So that's an indication. So that's what, this would be, well, that's toe plethysmography. It's not toe photoplethysmography, because that is an actual cuff. Kind of cute. Like you're doing a blood pressure on a chihuahua. And of course, we could do the same thing. We could do the same thing in the ankles. See how long the leg refills. Here, by the way, this is photoplethysmography. It's sending light in. I forgot what. All right, well, I'm sure it's in there, but I'm not seeing what it's, infrared light, ultraviolet light, something like that. And it reflects off of red blood cells, and so you have an idea of how much blood is in the toe. It's like, hopefully it's on a thumb. And this is actually similar to little finger oxygen O2 sensor. Uses the same type of light we have down here. Oh, that's smart. I just have another picture of air plethysmography. This one might be a little more appropriate to venous. And so here's the honest truth, guys. Never used, never even seen a venous plethysmography. This actually looks like arterial, but they're the same exact concept, really. So same difference. Dang it. This looks like venous. This looks like a much weaker cuff, but perhaps more sensitive to blood volume. Okay. Oh, and then they oh God, I've got to see. Well, you know what? I'll try to remember to get it for lab. Near infrared imaging. Some of the stuff they're doing now is crazy. How much detail can be seen, like just under the skin with near infrared diagnostic. We don't need to go over the diagnostic. Patient. Subject rests, leg is brought back. Patient stands over the non-situation. Yeah. Volume, much of filling rate. I think there's it's a little bit too on page 287, technique and required documentation. That's a little more than we need. And two is, since we don't have plethysmography here, I don't think you're ever going to see plethysmography in your time as a sonographer, unless you happen to go to somewhere that actually does these. And lastly, I understand. To be honest with you, I understand how it works. I understand why it works. I mean, I've never even seen that particular piece of equipment, so I'm not going to get into telling you something that I'm really not that familiar with. But I am familiar with, let's see, 416. I am familiar with the multiple choice questions and fill in the blank. You know what? I probably shouldn't do this, but I'm just going to go ahead just for this chapter, because I think going forward we're going to do something a little bit different. Actually, I think if I just pull this over, you guys see that, right? The different page. Here, let me look at the share. Actually, I'm not so sure you see it. Okay, now you should. Matching. Did anyone have any trouble with matching? Those were pretty straightforward. Let's just jump to multiple choice. And image. No, let's just jump to multiple choice. So this, can I draw on this? I wonder if I can mark up highlights. Draw, nice. Okay. All right, go away. Go away.
I was gonna ask for multiple choice number 1, was it a woman for that one? Because I got it wrong.
Yeah, you probably all did. There we go.
And then
Yeah,
I was going back, but I was pretty sure it was that answer, so I was like, no, let's just leave it like that. I'll ask.
Yeah, let me go back and I'm gonna give credit for multiple answers. The book actually says women. The book also very clearly, like I said earlier today, on one page, it gives ranges of men, ranges of women. They were essentially identical. Then the next page, it says, actually on the next page, unless you guys find something Prevalence, like I said before, varicose veins between 2 and 56% in men, which is a stupid wide range, and 1 in 60% in women. That is virtually identical. And then the next page, varicose veins noted more in men than in women. And then yeah, I mean, so I'm gonna give credit for men, women, and neither, because the book says both. I did quick research, and I found a big difference in people who are actually going to the doctor, and women go to the doctor far more often in general, but especially for varicose veins, but not necessarily a big difference between men and women overall. So yeah, I'll give credit on all of those. Okay, what are other causes of leg edema that may mimic venous obstruction? All the above. That's lymphatic obstruction, cardiac disorders, lipidemia. Patient presents to the vascular lab with visible spider veins. Based on this information, what would be this patient's clinical classification? Oh gosh, what was C1 again? Oh, jeez. Sorry. C1, spider veins, yeah. Telangiectasis and let's see, number 4, C3EPASPR. Patient presents to the vascular lab with chronic bilateral leg swelling, so edema. Upon duplex assessment of the venous system, the deep system was found to be unremarkable, although there was reflux demonstrated in the bilateral great saphenous veins. So EP for CVVI, vascular, there was reflux, yeah, reflux demonstrated in the bilateral great saphenous veins. So, all right, I didn't read that really well, but let's see, C3, edema, EP, dang it, valves, basically, CVVI is valve. A, what was it, AS, superficial, right, they said both great saphenous veins. And then PR, reflux. So we have reflux in the saphenous veins. That all makes some sense. Oh, there we go. Did you guys I literally could not find this. I mean, I knew what the answer was just out of kind of an educated guess, but venous pressure in the legs in a supine individual is 10 at its highest, whereas it increases to about 100 milliliters mercury with standing. That was in there, right? I don't know.
I actually found that one in one of the chapters, like in the way beginning of the book.
Yeah, like a different chapter, right? Because yeah,
Yes.
I kind of felt like I felt like that information came from a different chapter, but I didn't find it. I kept on going back and forth. But what is the reason for the increase in venous pressure with standing? Gravity, hydrostatic pressure. Within which of the following positions can a true saphenous vein be determined? Following positions. That's just weird. I'm thinking about the patient position. The saphenous fascia, the Cleopatra eye. Which of the following is aligned with deep system? Oh, aligned with the deep system, and that was a little weird. The anterior accessory saphenous vein follows on top of the leg, a little more in line from your perspective as an ultrasound tech. I kind of don't really agree with it anyway, but into which of the following vessels does a small saphenous vein terminate? Popliteal, gastrocnemius, distal femoral vein, any of the above. Before assessing the venous system for insufficiency, which of the following should be performed? Look for DVT. A, to best demonstrate valvular incompetence, which position should the patient be examined in? Standing. You want the patient standing when possible. When performing an examination for insufficiency, basically, CVVI, patency, and flow characteristics should be documented in all the following locations except the anterior tibial vein. So the basic requirements, this might not be your doctor's requirements, but the basic requirements for like organizations, I can't think of the organization, the tibial veins only if indicated. You don't necessarily have to do them if not indicated. You should be using spectral Doppler to do this. 14 is a trick question. And I wrote, right when I read it, I said, oh wait, what is distal? Pathologic flow or reflux occurs during blank of an automatic cuff when the cuff is distal to the side of insonation. Oh, yeah, and I got it wrong. But it's still, the question is, it's B, it's decompression, right? 14. Yeah, it's decompression. That makes sense. But the reason I say this is a bit of a trick question because are they talking about the technical difference between proximal and distal or the real life application? The real life application, the groin is proximal, the ankle is distal. But technically it's the other way around. So that gets a little confusing. So you guys understand this one though? Yes, no, you get that? Cuff is distal. Yes, yeah, that makes sense. Okay. Which of the following describes the proper use of an automatic cuff compression device? Rapid inflation, 70 to 80 millimeters of mercury. It doesn't have to close the artery, it just needs to squeeze. What is a major advantage of using hand compression? Adaptability. It's just sometimes easier to deal with, although it sure would have been nice to have an auto cuff when I was working. Which of the following is not a pitfall in measuring? Oh, that was just stupid. Low wall filter settings, allowing visualization. This is just a physics question, really. High persistence as in like averaging frame, that's gonna mess you up. High velocity scale, yeah, you don't need a high velocity scale affecting color sensitivity. And gain settings too high, altering setting of the spectral Doppler. Gain settings too high, altering the sensitivity of the spectral Doppler. I don't know what that means, I'll be honest with you. All right, after thermal ablation of the vein, what does sonographic findings include? You know, months later, years later, this thing's gone. You can't even see it, but potentially sonographically absent, fibrosed. 18 is D, right? I did this. I didn't realize I had a cheat sheet. I did this. Veins may recanalize at different locations, but probably not the vein that was actually thrombosed. Oh, I got 19 wrong. Valvular reflux times as measured on a spectral Doppler display are typically considered abnormal when greater than how many seconds? No, the book got it wrong. It's A. Does everyone agree with that? If you look at the chart or the box, 1 second is the highest number they have here. So that means anything over 1 second, no matter what you're in deep veins or any vein, greater than 1 second is bad. Less than 1 second is fine. So I'm just going to put a little note here. No. 20, what is the main purpose of venous photoplethysmography of the lower limb? Screening. It's not going to give you any kind of details. You're not going to know what exactly is going on. You just know something's going on. And that's reflux. What can the use of a tourniquet during venous PPG testing help determine? Deep versus superficial. Yes, because when we're using a tourniquet, this isn't like, this isn't Vietnam. You're not cranking it off and trying to stop blood flow to the entire leg. You're only squeezing enough to squeeze out superficial blood. So if you can stop. Well, if it's deep and it's not going to make one bit of difference if you put a tourniquet on lightly. Please don't be cutting off people's system. But if it's deep, it's not going to make a difference. If it's superficial and you squeeze it here, you're going to get blood past the tourniquet, then it won't come back down. I've never used a tourniquet doing this, but it stands to reason that it's certainly going to affect your scores. I have to think about that, though. Let's see. A patient presents to the vascular laboratory for evaluation of valvular incompetence. Venous PPG examination performed. The results of the examination demonstrated venous refill time of 10.5 seconds without the use of a tourniquet and 22 seconds with the use of a tourniquet. Okay. Think about that for a second. Deep venous reflux, right? Number 22. Presence of superficial. See, I knew that, but I still got it wrong. And that's why we pay attention, right?
So 22 is
22 is actually letter C. I got to change that.
okay, yeah, because I got it wrong in the test as well.
Yeah, that's my mistake. Because just like I finished saying, the tourniquet is going to affect the outcome if it is superficial. If it's deep veins, it's not going to affect the outcome. And so when they put the tourniquet on, it took longer to fill. They took the tourniquet off, it took half the time to fill. So that tells you that it's refluxing. It's the legs are filling with both artery and venous blood. So reminder there, fix that. Air plethysmography, quantification of chronic venous insufficiency. Still doesn't give us a lot of information, but it does quantify how much basically how much volume is going back into the leg and how quickly. Using a air plethysmography, APG, increased ambulatory pressure is suggestive of the inability to empty the calf veins owing to poor non-functional heart indicated. Increased ambulatory pressures suggestive of the inability of the calf veins owing to pump owing to poor or non-functional calf muscle pump are indicated with which of the following findings. So yeah, a residual volume of greater than 20 to 35%. In other words, even with walking, even with flexing the calves, blood is not leaving the veins or leaving the calf, and that would certainly cause a lot of pain. Which of the following is emerging technology that will help with the guidance of venous access? Near infrared. Like I said, it's really cool. 433. This is going to get long if I go through all the fill in the blanks. I'll tell you what, guys. I'll provide them to you. Let's skip to. Oh, that's right. When I do this, I can't undo my mistakes here. Here we go. I'll provide you with short answer. Let's talk about, okay, did you guys look at the case studies? Yeah. Oh, wait. In the image evaluation, actually, I didn't look at the image evaluation, but that's pretty easy. It better be, right? This image was, so starting on the top of page 164, this image was taken in the great saphenous vein, distal to the saphenofemoral junction. The patient was asked to perform a Valsalva maneuver. So you don't always have to squeeze, right? You could Valsalva, and this image was the result. Explain the findings and if they are significant. Well, person took a breath in, pushed down, and the blood went backwards. That's significant. So they've got at least a couple of valves, probably more, that are refluxing. You know, if you think about it, if you have bad valves in the superficial and bad valves in the perforators, and you do a really long Valsalva, that blood won't stop. It'll just keep going down through the perforator into the deep system. And, you know, pretty much until you empty out your entire IVC, it won't stop. And so what does it say? This image depicts retrograde flow within the great sinus normal cessation of flow. In this case, compound line backflow such as yeah, some degree. Yep. This image is of the left saphenous vein just distal to the saphenofemoral junction. Describe the structure the white arrow is pointing to. What is its purpose? Oh. Well, either radio or laser ablation, thermal ablation of some kind, yeah. So what you're seeing there, assuming you guys have your books with you, is a catheter with a real hot tip. And here's a hot tip for you. Don't leave it in there because it'll burn your skin. So it's being pulled out, boiling the blood, basically, causing instant thrombosis. Okay, case study. A 44-year-old female presents to the vascular lab with a, I need my, oh wait, I'm just gonna put my sketchbook over here. Okay, close enough. I guess you don't really care about that. Look at all of those. Those are all stuff that you would love to get your hands on. Where am I? Sketchbook. Where'd it go? I need chapter notes. I guess I have to pull it back up again. I don't know what happened to chapter 20 here. It's not. Am I blind? It's right in front of me. Windows can't. Yeah, well, do it. Sorry about that. I don't know really why that happened that way. I think I'd find it on the, anyway. Okay, so for her classification C2EPASPR, she has been referred for verification of this classification by duplex testing. So duplex testing, someone's already done an ultrasound under her, for her, but perhaps someone like me who's not quite the expert specifically in this exam, so then they sent them to a vascular lab for the doctors who are also specific. Explain the CAP classification for this patient. What duplex protocol would be most appropriate for this patient? What would you expect the findings to be? Well, that's a lot, so let's see what they said. Classification indicates that the patient has visible varicose veins. C2. Wasn't that C3? Oh no, C3 is edema. C2. and chronic venous valvular insufficiency as a major cause of clinical manifestations. So we said EP, CVVI. Insufficiency affecting the superficial veins, AS, and reflux or reverse venous flow as a primary pathophysiologic condition. Reflux or reverse, and that's PR for reflux, okay? Reflux is demonstrated in the right great saphenous vein as well as the right femoral popliteal veins. From the findings on the right, that's, she's had what duplex? Oh, that's number 2, I'm sorry. I thought that was point number 2 of, I think I just skipped, did I skip the entire paragraph? This patient would most likely benefit, yes, I skipped the paragraph. This patient would most likely benefit from a full diagnostic evaluation. Shit. Patient has visible varicosities and would likely be a good candidate for minimally invasive treatment, like ablation. Evaluation of the D system to ensure patency with detailed evaluation of the superficial system to determine the precise source and outlet or retrograde flow would be appropriate. Precise source, I mean, if you can show the doctor, if you can show the doctor, you know, exactly, all right, go away. Skipped. Which valve is actually refluxing. So it's usually not every single valve. That would be great. This vessel would most likely be the source of pathological condition. Okay, number 2, 52-year-old female presents to the vascular lab for varicose vein evaluation. Findings during the evaluations were as follows. Right great saphenous vein, visually enlarged and tortuous. Retrograde flow lasting 750 milliseconds. And what do we say? 500 milliseconds is the top end of normal. So that's definitely reflux. Retrograde flow is also visualized with color throughout the entire length. Left great saphenous vein visually appears to have normal diameter, minimal retrograde flow, less than 350. That is normal for a saphenous. Right femoral popliteal segments, thickened vessel walls with mostly anechoic lumens that are not fully compressible with transducer compression retrograde flow noted at 1.2 seconds. So that sounds like someone who used to have maybe occlusive DVT. They were given anticoagulant therapy. It went away, but it's not all the way gone. So they still have some problems, but they, you know, fortunately they have blood flow now. But left femoral popliteal segments, anechoic lumens that are compressible with transducer compression with minimal retrograde flow, less than half a second, 500 milliseconds, less than half a second. Less than, okay. Which vessel demonstrates reflux? The vessels that demonstrate reflux, which is most likely underlying pathophysiology. So, great saphenous vein, you can see that clearly, femoral popliteal vessels as well. From the findings in the right femoral popliteal vessels, the most likely cause of the reflux is deep vein thrombosis, obstruction, creating reflux in both the deep and superficial venous systems. So by the way, guys, so that's, let me draw something right here. Go away. So let's say we have a normal system here, but we have DVT. The entire leg starts filling with blood. And this is chronic. This isn't just short term, this is chronic, chronic, chronic. Eventually, this can go to something a little more like where the valve leaflets simply don't reach. And so with chronic obstructive, what happens is that just the vessel gets bigger and bigger from all that pressure, the valve bulb gets bigger, and now the valves, they, in a sense, they're functional. In a sense, we just lost John. They're functional, but they're so far apart that blood can go backwards through them. Okay, 3, a 67-year-old male, 444, okay, presents to the vascular lab for venous plethysmography testing, air plethysmography testing. Standard APG test is performed with the following results. Oh, I don't know these results. I didn't look at this one, honestly. Venous volume, 200. Venous filling time, 10 seconds. That's pretty fast. I know that. Venous filling rate, 2.5 milliliters per second. Probably fast or large. Residual volume percentage. In other words, it's volume that doesn't quite leave. That's bad too. What do these results suggest? Increased venous volume suggesting venous pooling. Yeah, short filling time suggestive of severe reflux. And so not only the artery, but the veins are filling the calf. Increased filling rate also suggests venous insufficiency. Increased residual volume suggestive of increased ambulatory venous pressures. In other words, even when this person's walking, they can't remove blood from their calves. So that's a double whammy. All testing indicates this patient has moderate to severe venous insufficiency. Because APG does not determine the precise location and vessels involved in the venous insufficiency process and location and the vessels, duplex ultrasound evaluation would be suggested to completely evaluate the deep insufficient systems. So yeah, plethysmography. I am not a vascular specialist. I'm actually pretty good at vascular, but I'm not a specialist. I don't really care to be doing plethysmography or anything else with a cuff. It's not. I don't feel like it's my job. I feel like this is a job for nurses. But they're easy. I mean, don't get me wrong. If I had to do them, I would learn them in about half an hour, because these are generally easy. I actually owned a plethysmography unit. It was for arterial plethysmography, but I actually owned it for a while and ended up selling it to someone else. But I wish I kept it now, just for school. But and that was easy. I learned how to use it a couple of times. I just practiced on my wife, and then that was that. So easy to do. Don't be intimidated by some of these exams that involve tools that we don't have in our lab. Trust me, ultrasound is far harder, far harder to do than any of those other peripheral exams or those extra exams. All right, I have so many things open, I don't know where I'm going. Give me there you are. And the controls are over here. Let's see, pause here. So, question, do you just see me or do you see nothing? Is it that?
Let's see the page with the case study on it.
I guess new share, I just want to. But I don't know, I don't want to share at all. Whatever. Whatever. Okay, let me just pull you over here, guys, so I can see you. We haven't talked about testing at all, have we? Yeah. Okay. Okay. We have. Let's see. I ended out with you on 19, right? I talked to you about venous mapping. We've only been together for 2 weeks, right? So venous mapping and now venous insufficiency testing. Sonography in the treatment room. We'll only talk a little bit about 21 and 22, I think. I need my, now that I put this here, I don't want it. I got a new computer and I don't understand where things go sometimes. You just kind of lose it. 242. Civil line outline, course schedule. I definitely had you open earlier, so what happened to you? Okay. There we go. Are you guys in week 5? Are we doing good here on, you guys know? I can't remember. I don't know when you started.
I think we're in week 7.
I thought it was week 6.
So
It's starting to sound really horrible again.
okay. Well, I that's true. You were trying to get rid of me. Okay, so you guys understand chapter 21, 22.
Honestly, I really can't. I hear something about chapter 21, and that's it.
That's mine. My line. It's over here. We are.
He sounds like Darth Vader.
Bad cold. And a really big echo.
It's back.
It wasn't backwards. I was able to read it.
It wasn't backwards. Oh, it's back for me. Okay. Adios.
Adios.
I'll email you. It's not back, so that's it.
Adios.
I
I take care.